Session 3. We are joining here today on March 15th, 2023. Thanks for joining us, everyone. Bethany Hamilton of the National Center. All right, let's go to the next slide, Nola. I'll roll through the all the housekeeping stuff very quickly here today because we've been together already, really, for the last 3 years on Zoom. So as you know, in this learning collaborative, you are encouraged and welcome to use the chat. In just a moment, we'll ask everyone to just remind ourselves of who's in our cohort by typing some information into the chat. But you are automatically joined on mute. If you do need captions to activate them, click on show captions, and then you should be able to click just maybe one more button to have those captions appear on the screen. Also, this session will be recorded, and we'll make sure, as I mentioned, that they are available to all cohort participants. And please, if you've got any questions, really the easiest place to put it is right there in the chat. Just make sure you chat to everyone so that everyone can benefit from both the question being asked, and we can make sure that facilitators are able to see it and answer it. We'll do our best to get to all of that. Next slide. All right, as you all know, this is funded by HRSA, but we are very happy to have not just health center MLP practitioners join us, but those who are carrying out this work at different types of settings, including hospitals, maybe even health plans, or federal agencies or local or state government to help enrich the conversation and our learning process. Let's go to the next slide. Thank you to HRSA. Again, as Danielle, our colleague who's now going on to do global maternal health work, has noted before, this learning collaborative is designed to really help us improve those community strategies that improve maternal health and health equity through health centers. We're going for 4 sessions. They're each 90 minutes each, so we'll wrap up today at 2:30 p.m. Eastern Time. Make sure you've changed your clocks, those of us who are into changing clocks. And we'll do both an overview and have a discussion. Nola Booth has deliberately designed today's session to not just engage along the way through the didactic portion, but also at the end. So let's go to the next slide. I'll just provide very, very brief introductions. We've done this twice now already, and it is in your welcome packet. I just want to make a note about the welcome packet. If you do not receive it, if you don't have it anymore, please feel free to send an email to ncmlp@gwu.edu, or just, again, I'm Bethany Hamilton of the National Center. You can email me as well. But we'll go over the presentations, have a discussion, and then we'll close out. Nola, can you take me to the next slide? Thank you. Also, as you've heard Danielle mention, we're helping you to better understand how MLPs, medical legal partnerships specifically, for those of you who are a little bit more at the beginning stage, better understand how MLPs play a role in maternal health, help you understand how to detect and address those unmet legal needs that are a subset of social needs that may negatively impact maternal health incomes, and then develop and strengthen your strategies to collaborate across these different settings at health centers or hospitals, those healthcare settings, as well as the legal settings, which you may see as we walk through this learning collaborative can be a legal services organization, such as where Nola Booth is from, or maybe you are able to tap into law schools for your legal services aspect of your work. All right, let's go to the next slide. You all have met the faculty before. I just want to highlight that in your welcome packet, you have full bios for everyone, but today's session 3 is really being led by and facilitated by Nola Booth, who's an attorney starting up the MLP for Legal Assistance of Western New York, or Law New York. By the way, this is my personal plug. That's where I got my start in civil legal services work. So I'm very happy to have this opportunity to introduce Nola Booth from Law New York to everyone here today. She also works for and adjacent to my old boss, Keith McCafferty, who's a managing attorney of the Law New York offices. So Nola, I'm just going to let folks know what to look forward to, and then I'll pass it over to you to begin your presentation and guide us through the discussion. Again, I encourage everyone, please use the chat. Let's go to the next slide. Speaking of, when Nola presents, we want to make sure folks are able to begin thinking about what the group discussion will entail. Hopefully, you all will have a conversation about, from healthcare providers' perspectives, about what your current practices are for patients or clients that are affected by SUD or substance use disorders. Not just opioid use disorder, by the way. We want to keep it broad and talk about substance use disorders generally. Think about the institutions that these patients are encountering, and are they requiring things like universal urine drug screens? Are they doing verbal screenings? And then what happens when someone screens positive? For those of you who are from the legal settings or legal partners in MLP, do you take clients, or excuse me, do you take on the family court cases? Do you take on the neglect cases? And then how are you navigating relationships with healthcare staff on those sorts of topics? Are you providing trainings? Are you guiding folks through the specific types of screening questions as they approach the patients? And then what, if anything, are your organizations doing to address racial disparities and inequities in maternal health? And then how are you documenting your successes in a pediatric context? These are some of the things that Nola Booth will walk through in her presentation about MLP in rural settings. Nola, I'm just going to have everyone using the next slide, use the chat to tell us who they are, their titles, their organizations, where they're at. And then if you can recall from Courtney Mendoza's presentation, Courtney's also joining us again here today, share a takeaway from session 2. So I'll type that instruction into the chat just to make sure folks are able to chat while you present, Nola. But again, let's make sure we all remember who we are as a cohort. Put your name, your title, your organization location, and then a takeaway from Courtney Mendoza's session 2 presentation. Thanks, Nola, all yours.
Great. Good afternoon. Hi, I'm Nola. I am an attorney pending admission in the next like 20 days. I'm up here at Law New York in Ithaca. I'm here on a 2-year Skadden fellowship, but I've been working as an extern since the summer of my 2L year of law school here at Law New York. So I'd already been here for some time before my fellowship began. My project has been to develop a perinatal medical legal partnership with Cuba Medical Center. That is the hospital that is associated with our rural county with a population of about 105,000 when I checked this morning. I want to start out by saying that I'm pretty sure the babyest MLP on among the session collaborative presenters, but I started the MLP in earnest began last September, at the end of September 2022. So I've been at this for about 5 months. But my hope is that my nascent perspective will be useful to folks who've yet to start their MLPs and folks who are looking to expand into the maternal health arena. But please keep in mind that I, like you all, am here to learn. That's one reason that I hope to leave ample time for discussion at the end, because I want to get something out of this too. But I hope that I have something to share with you. So let me introduce the organizations that are at play here. I work for Law New York, which stands for Legal Assistance of Western New York. We are a nonprofit law firm that provides free legal assistance to 14 counties across Western New York. We are where there is green highlighted on our logo. So that part of the little map of New York that's green, that's where we are. And I specifically work with Finger Lakes Legal Care, which is a medical legal partnership that was sponsored in part by Law New York in the beginning. We are a tiny cohort, but we are mighty. And I will get to how that kicked us off the ground in a second. So back in, I think, October of 2012, my partner attorney, I don't think we have any official work relationship. I call her my supervising attorney a lot. I'm pretty sure I'm not supposed to do that. But Rebecca Russo, who's on this call, started an MLP back in October of 2012, tabling at a cancer center at Rochester Regional Health. Rochester is up in Monroe County, and since then has expanded into URMC, University of Rochester Medical Center, and a couple of other campuses up there. Been going for over 10 years strong at this point. I grew up in Tompkins County here in Ithaca. I started it. My legal education was from Cornell Law School, but I was born at Cayuga Medical Center, which is my partner medical provider. I've had 2 children at Cayuga Medical Center, and I was on Medicaid when I was pregnant with my first, and that was only possible thanks to assistance from my local Human Services Coalition. I wouldn't have had that benefit if I hadn't appealed to my community resources and taken advantage of the people who were here to help me. And I think that all of those factors, the fact that we had an existing MLP in another county, and the fact that I had a connection to this county, contributed to our success in my getting a Skadden Foundation Fellowship for 2 years to extend the MLP model here to Ithaca. So also helpful, I think, in obtaining that funding was the data that we have from Rochester. This accounts for about 105 months. It's a little bit out of date at this point, as you can see, but one full-time attorney with with some extra help thrown in there was able to achieve over $50,000 in benefits for clients up in Monroe County who were participating in the Rochester MLP. Rebecca was able to obtain close to $150,000 in retroactive payments, discharge over $75,000 in debt, and help a bunch of other folks with legal outcomes that are not so easily quantified, right? But we were able to tell this to Skadden when I applied, and we were also able to tell them that Rebecca has saved the hospital almost $2 million in claims that wouldn't have otherwise been paid. And that $2 million in savings for the hospital has led for the hospital to pay for the programming in large part, and to contribute to this service as an ongoing benefit to them. So those are some really cool things, I think, about our current project model. It's both, my project in particular is dependent on my fellowship funding, but there are other ongoing funding streams at play, and Rebecca can maybe talk about later, but there is hope in that regard. The other thing that I think was important to my successful fellowship application was the data that was available and identifying the population that we wanted to help. So Tompkins County produces a community health assessment and a community health improvement plan every so often. This is the previous community health assessment. There's another one that I will get to momentarily, but when I started pouring through our community health data, I realized that more than half of the families in Tompkins County with single moms at the head of their households and children under the age of 5 are in poverty. And if you look specifically at the city of Ithaca, which is one of the larger cities in Tompkins County, it's where Cornell Law School is, it's where Cornell is, it's where Ithaca College is. 80% of those households headed by single moms with children under the age of 5 are in poverty. And that's, wow, right? Like that's enough to open somebody's eyes. And it's something that everybody in the community already knew. It was something that I had a sense for just from growing up here and from working at Law New York and from being a part of this community. But it was good to have the numbers to put on the table. And we also know, now this is from the most recent community health assessment, but we know that the rate of births with late or no prenatal care is more than 5 times higher for Black and Hispanic residents of Tompkins County, which is another wow, right? We know not only that there are poverty disparities for folks with young children, we know that there are racial inequities happening here too. And I can say from a community equity meeting I was just at on Monday with a bunch of our local service providers and stakeholders, part of this is because of a distrust of the healthcare system. That was something that was identified in community surveys, is folks are just generally in our county avoiding care because of a myriad of factors. But regardless, we know that these disparities exist, and we could name them to the potential funders. So you've got your funding, you've got a person like me. Now what? We talked a lot about Equal Justice Works last week, but I want to talk for a minute about how you start collaborating. Because the first thing that I think you should do if you are looking to start an MLP or you're looking to work with a new population and meet a new need is figure out who's already doing the work that you want to do. And that means you need to embed yourself in your community. These are some of the organizations that I worked with, and these are an invaluable part of what I have been able to achieve so far. I can't overstate how much it's meant to me to meet these folks, to travel in these circles, and how much time and energy it has saved me to pay attention to the work that they're already doing. So I've put on here Northeast Pediatrics and Adolescent Medicine. That's one of the major pediatric providers. They are not owned by the hospital, but their physicians have admitting privileges in the hospital, and they see every child that's born at Cayuga Medical Center. They have been a source of referrals for me since I've been able to meet with their pediatricians, and I found one particularly enthusiastic doctor to be my champion, right? Tompkins County Whole Health is our health department. It's our health department merged with our mental health services provider, but went to some meetings. I went to some meetings about access to healthcare, and I found that we had community health nurses working to meet with new parents when they went home from the hospital with their babies. And me, as a person hoping to tend to the legal needs of new parents and people who are pregnant and people with young children, of course I should be talking to them, right? Because they're doing home visits. They see these people every day. Well, not every day, but often, right? Family and Children's Services of Ithaca is another. They have a whole army of social workers that do street outreach. Reach Medicine specializes in treatment for folks who use drugs or folks affected by substance use disorders, and they are central to advocating for folks who use substances and deliver at our local hospital. And we'll get to more of that later. And then finally, the thing that has really been a goldmine for me that I'm still working through, Cornell has the Masters of Public Health program, and I happened to go to a meeting. I happened to find out that they were already doing social determinants of health screening, and they were implementing it in several offices, including the OBGYN's office. So my entire plan to try and get healthcare providers to maybe start using a screening tool for me became unnecessary because somebody was already doing it. So again, community. I think for anybody who wants to get into this, that is the most important recommendation I can make. So my first question for you, because I have now emphasized the importance of community ad nauseum, is what community organizations are you already collaborating with? Are these organizations a connection to the world of pregnant and parenting folks? And you can feel free to unmute, you can put it in the chat, and I will name what I hear if you type it up.
I'm going to encourage folks to just hit unmute so that we can feel comfortable talking. So I just for folks who, in case they do want to use the chat, I copied and pasted Nola's question in the chat again. It's what community organizations are you collaborating with, and are these organizations a connection to the world of pregnant and parenting folks? But I would encourage folks, if you're in a setting where you can talk, let's talk.
Hi, I can unmute. This is Clinton Householder
Thanks,
from
Clinton.
Community Legal Aid in Northeast Ohio. We do collaborate with quite a few organizations that are connected to pregnant women, and then also women who have young children in the home, mostly under the age of 1, but above and beyond that. We partner with like the health department, behavioral health care providers, most of the area hospitals and pediatric locations, just a wide range of different healthcare partners in our community.
Thanks, Clinton. Nola may have a follow-up question for you, but Nola, in the chat, I can read out another response. Henry Martin, who's from, or Henry, I think you're out in Watsonville, if I'm not mistaken. Is that right? Hopefully there'll be a typed response, but Henry is identifying partners from the FQHC, Watsonville, California. The FQHC, Migrant Health Centers, a hospital delivers 9 of, Zoom pop-ups are getting in, 9 of 10 babies in our region. Healthy Steps partners are also identified as well.
This is
Anyone else want to share? Hi, Holly.
Hi, this is Holly in New Hampshire at Dartmouth Health, and I can share our MLP is actually integrated in a community site for one of our site locations. We're in a family resource center that does parent and child home visiting. They do nurse home visiting, they do lactation consulting. It was sort of a natural connection as we've done a lot of work in our pediatric settings in those regions. And then our other setting is a treatment center, a full service substance use disorder treatment center, which receives medical and community-based care there for moms and babies as well. So very community focused. So I really appreciate, Nola, your focus on community because and how we interconnect with the healthcare setting and our community settings.
Holly, is the treatment center you mentioned about for folks with substance use issues? Does that treat moms while keeping them with babies in the same place?
Correct. Both. So it's an outpatient center. We are working hard on some improvements to inpatient settings, but it is an outpatient center and it is pregnant and then postpartum moms and keeping them with babies. Correct.
That's terrific.
And yeah, and we've actually kind of hit this gray zone with our MLP for that population, both settings in particular. But we have a catchment group for under the age of 7 for our focus, and then obviously pregnant parents. But we really also don't want it to be hard and fast that you have your kiddo, so that if you're working to reunificate, that we can provide MLP services. If you're working towards various things that we want to include those patients and populations as well.
Amazing. So cool to hear.
Nola, can I just read out one that came in the chat that is interesting because I think it offers folks yet another way to stay connected. And Julie Wingfield, I'm going to read out your chat in particular. I don't know if you want to unmute before I dive in. You're welcome to do so. Just unmute and talk if you'd like. Here it goes. So Julie Wingfield is actually serving as a board member of a health center, community healthcare in Flint, Michigan, that works to impact infant mortality. And as Julie noted, that helps her keep a pulse on the important issues, as Julie's noting that she's a legal services attorney, but serves as a board member for that health center. So Revive Community Health Center also provides resources and wraparound services to expecting mothers that promotes decreases in maternal and infant mortality. It addresses infant low birth weight, and they also address premature birth rates for babies in Flint and Genesee County. I just want to note that is an awesome way to also connect with and embed yourself with the community, even if it isn't directly connected to the medical legal partnership services. Thanks for sharing that, Julie.
Thanks for reading that out. It's very important, even though it was hard for me to initially understand how to connect with this community of like-minded individuals. I think that serving on a board is another way to make sure that when the time arises, there's a good way to step in and know something about this important connection between medical legal partnerships and how data, as you mentioned, could be quickly connected to make an impact. Thank you.
Thank you.
Awesome. I'm going to press forward, but we have lots of other opportunities. I'm sure this will keep coming up. So let's talk a little bit about what the work looks like for me, because I am just getting started, but I think it is interesting to think about what supporting the legal needs of my clients in the perinatal context looks like. I should mention at the outset, we talk a lot about health harming legal needs, and the rough definition, which I have stolen from the NCMLP website, is the subset of a person's social needs that have potential legal solutions. And that can include things like legal aid essentials, the things that we typically think of when we think about legal aid: evictions, public benefits appeals, domestic violence, consumer debts, reentry, Social Security, things like that. But there are needs that are very specific to my population that aren't necessarily addressed by the things that my legal aid organization typically does. I meet every week with the social worker in the labor and delivery ward at my hospital, and we talk about what's coming up in between that and my conversations with folks in the community. The rough subset of things that I handle that other folks here don't handle includes lactation support. So folks who have a boss that won't give them time or space to pump breast milk, right? That comes up. Part of my job is to let people know that they have that right and to potentially write a letter of support or write a letter explaining the law and that the manager may be in violation of that law, that sort of thing. Paid family leave in the same vein. Different states have different entitlements when it comes to paid family leave. New York has a fairly robust paid family leave statute. And part of what I do is tell people that they're probably eligible as long as they don't fall into some of these accepted categories. But there are protections in place that are not often upheld. Employers sometimes will just say, no, I don't participate, I don't do that. That's not necessarily true. Health insurance issues come up. We have a pretty good network of folks helping with the application process in Tompkins County, but when things like claims disputes come up or denials, we are able to, those I can pass on. We have a community health advocacy project that's regional, and I reach out to our health law attorneys to deal with those cases. CPS or DCFS, depending on where you are, Child Protective Services, Protective Services or Department of Children and Family Services. That one has been a big one. And it's been a big point of contention and interest for me. That's part of why a lot of my questions resolve around substance use issues. Because my hospital has a universal drug screen. My hospital screens every single person who delivers at the hospital, and certain screening positive for certain substances and having your baby screen positive is an automatic call to CPS. And the first question that my social worker asked me when I showed up was how she could be supporting families when CPS comes in, makes a promise about treatment, rehab, and getting your baby back, and they can't follow through on that promise. I don't have a solution for that yet. I will talk a little bit about that in a minute, but I just wanted to note it here. And then finally, the thing that I am now dipping my toes into is special education services, and things like occupational therapy, accessing things that the county owes to certain children under the age of 3. And then I think from like 3 to 5 or 6 is pre-K special ed, and then it gets into special ed. I'm lucky we have a really, really good special ed attorney up in Rochester who will advise on these things, but still something that comes up in the population. And before I get a little bit more into depth on some of those issues, another question, which is, what are the biggest health harming legal needs you are seeing among your populations or anticipate seeing in your client populations if you have yet to get started? Pete.
I'm really curious to hear this one, Nola, especially because of what you just presented, and you're also presenting from a rural setting. And so I'd be really curious to see if people are seeing similarities or distinctions if they are not in a rural setting, or perhaps, New York presents a different set of scenarios. Very intimidating experience having to do screening upon delivery for any type of illegal substances. Excuse me. So I imagine patients perhaps could be avoiding those settings.
Rebecca pointed out, hi Rebecca, poor and sick housing conditions. And I know this because we talk about it every week, but that is a big one. I think I leave it out sometimes because our housing attorneys sometimes tackle it, but it is something that I've had to tell my housing folks that even if they wouldn't normally take a case because they're typically only getting involved in like eviction scenarios, I can do advocacy with doctors around housing conditions cases. Let's see, Holly says housing closely followed by family law issues, lack of affordable and quality housing. Buffalo's biggest problem is housing, family law and housing, tax foreclosures. That's a big one. We do that. We do that too. The attorney across from the hall for me does those. Immigration, housing, employment, and insurance, immigration related needs, access to state maternal and family leave, housing conditions, and employment. Yeah, so let me say something really quickly about immigration. So the funny thing that you may or may not know about Legal Services Corporation, which funds a lot of legal aid organizations like mine, is we have a citizenship requirement or a documentation requirement, which is really unfortunate because when I meet a person in person, I have to give them a form that says, I swear I'm a United States citizen, and they have to sign it before I can represent them. That's obviously a barrier to legal services for many folks. But that's part of the structural constraints of what I can do. So that is something that I've been interested in hearing from y'all about your work in immigration spaces. Bethany, I didn't mean to take over your job of reading these.
No, this
Sorry.
is you. I'm just helping you. That's perfectly fine. I am also interested. I saw a couple of people put immigration and immigration related needs, and maybe they can also help, especially the health center folks who are very much interested in working more with their patient populations to address those immigration law needs. I feel like we should let's do some open mic now or at the end, whenever you'd like, to help folks understand how to navigate those issues when they come to the legal services providers that are unable to, depending on the restrictions, provide those services and how they work through those.
Yeah, I mean, I'm happy to hear now if there are suggestions that folks have for folks who are seeing immigration related services like issues like me, because I see them, what you would recommend, how that referral process should go, where we should be looking to send folks. Because right now I have one organization and one attorney at our local Catholic Charities that kind of gets all of our immigration stuff. And I'm not sure that that's the best outcome.
Working backwards through the list, just so folks know, similar to HRSA funding, Section 330 grant dollars to health centers, LSC is the federal agency that provides similar large grants to LSC funded legal services organizations, a lot of whom are involved in medical legal partnership. Henry Martin noted that they are not LLC funded out at the Watsonville Law Center, which partners with NFQHC, and they are therefore able to serve undocumented clients. As we know, California made major pushes a few years ago to provide additional coverage, such as through Medicaid, for undocumented individuals. Henry, even though you're not LLC funded, are you still seeing any challenges or barriers, or can you tell us how you navigate referrals or issues? And then I don't know if someone is LSC funded in the mix and wants to add a little bit to the conversation here. Henry, if you would. Yeah, thank you. Thank you.
I think I could come on mic here. I shooed some folks out of the space. I know this is a very difficult thing, and we partner with LSC funded legal aid organizations. So I understand, as a legal aid administrator, I also understand the problem from the LSC funded organization's perspective. I think it's good to have partnerships between the legal service providers who have restrictions and the legal service providers who do not have restrictions. I know that's not possible in all areas, but it is something to look for. And then I know, and I say this tremendous compassion and love for the LSC funded organizations. They do a lot of the heavy lifting in legal aid across the nation. And these are obviously not restrictions of choice. It's imposed on you by your funding. But I think as a baseline with our FQHC, because it is a migrant health center, it serves a large undocumented population, we had to come up with systems to disclose that so that an OB doesn't refer a highly stressed pregnant patient to a legal aid office who's going to turn them away or ask uncomfortable questions about immigration status. And then I also want to point out, this is not just for immigration, that if someone has a housing problem or problems accessing public benefits or especially employment problems, it's a critical part of the legal case to find out whether they are documented, to find out whether they have lawful work authorization, to find out if they're using a false identity or false credit information. And so it's not something that you can just, don't ask, don't tell it doesn't really work in this space. You can't just pretend someone's not documented and serve them as if they did not have immigration status. We try to treat immigration status as a primary social driver of health.
Thanks so much for sharing, Henry. The National Center actually is hosting another learning collaborative that happens on Thursdays where we do talk about the recommendations for healthcare providers and who are, we know, faced with tremendous barriers because of, the change to the public charge rules. And then a change back, right? And then having to address the deterrent, chilling effect that the rule change had. And so if anyone from the healthcare space has any questions for how to, as Henry noted, not pretend that it's not a real health harming barrier, how do you protect your patients / clients from the effect of sharing that critically important information? Please put it in the chat. Let us know. Henry, hopefully folks can reach out to you if they've got questions as well. Okay, thanks. And thank you for sharing. Nola, I'm going to defer to you on how you want to proceed.
I'm going to keep going, and there was always going to be time to talk at the end because there's just some stuff I want to get to first. It would be a disservice to you all not to be transparent about the things that have come up that I didn't anticipate that this early getting something off the ground, right? Because maybe I can spare you the same mistakes. The first one's less of a mistake and more of just something to think about in the fellowship sphere. The way that these things are set up for law students in particular, there's just not very much time given for planning. So, for example, I was in my second year of law school. I finished my fourth semester. I started working at Law New York part-time because I just had a baby, and I developed a relationship. But the way that the typical summer semester block works, we're expected to work June and July, do interviews in August, and then resume classes at the end of August and September. All of the fellowship applications are due early September. So really the time that we have theoretically is that month of August to come up with and complete our fellowship application. So without substantial support and buy-in from the organization we're attempting to partner with, that doesn't happen. And I was fortunate enough that I have grown up here in Tompkins County, and I had developed a relationship with my coworkers just during those 2 months that I was working here, that I could prepare an application, and that the folks here were behind me, and I had several attorneys and folks from our pro bono team who helped me through that process. But it takes a commitment, and ideally I would have had more time. I would have consulted more folks. It's okay. I'm doing some of the work that I would have done it beforehand now, and that's okay, but it's just something to keep in mind. The second is the point that I touched on earlier that I want to stay with for a minute. I've called it navigating conflicts. That's kind of a legal way to look at it, I think. But as we've already discussed in this collaborative, most doctors and social workers are mandated reporters when they are a treating physician, when they're acting in that role. And from the conversations I've had with medical students and healthcare professionals, folks are generally encouraged to call and make the call in order to protect the child, but also to protect their license, because the health of their license may depend on them making a report. And I've had to think about how I want to handle cases where CPS is called and where neglect is potentially being charged, because the hospital's interest in those cases may not be those of my client. The hospital has an obligation to the state, to the doctors, and to the baby, not just a parent, a mom who's postpartum. Tompkins County has an assigned counsel program, meaning that folks who are party to people who are charged with neglect, it's not a criminal charge, but I'll say people who are served with a neglect petition, as well as other family court issues, are generally entitled or eligible for free representation if they meet the criteria to be found indigent, right? And this includes folks who give birth at the hospital, screen positive for an opioid or methamphetamines or another substance, depending on what hospital you're in. The policies are different, which is also a challenge. If they screen positive and CPS is called and CPS chooses to proceed with a neglect petition, those folks will be able to get an attorney locally for free. And because of that, I have to let those attorneys right now take those cases. And the reason is that sometimes the Department of Social Services will subpoena nurses or the social worker that I meet with on a weekly basis to come testify about what they've witnessed at the hospital, in the delivery room or in the recovery room. And if I were that parent's counsel, legal counsel at that moment, I would have to be willing to cross-examine the nurse, the social worker, these healthcare providers, and potentially undermine their credibility in order to appropriately advocate for my client. I can't be in that position right now when I am just trying to develop a positive relationship with the hospital, when I'm trying to get to know these nurses, when I am trying to get folks to send me people to take care of and to not just take care of, but to serve, right? To help out in crisis, because they're going through very difficult moments in their lives and we all just want to work together to make their situation better. But I can't ask them to trust me if they are up for legal attack by me. One of the things I want to talk about at the end is how y'all are handling these cases if you're taking family court cases. But I know that some folks on this call, I think Roxy, we were talking about this, you work with medical providers in slightly different contexts. Roxy was telling me about medical students who consult on cases and can provide a new perspective, and how for them it's about explaining to those folks that when their mandated reporter responsibilities apply and don't apply. And I should also underline that I have professional responsibility guidelines that I have to adhere to. So I need to be mindful of whether a situation is becoming truly unsafe and if I need to make a call. Because what we want is healthy families staying together. We don't want a bad outcome. But we do want to advocate for what's right. There's a lot to say here, and I want to hear from you, but I just want to navigate through the last 2 points before we get into sharing some more oops moments. Getting referrals. Let me be very vulnerable and tell you that in the last 5 months, I have maybe gotten 2 real referrals that were carried out in the way that I had intended and planned, right? Meaning either a doctor at a practice gave somebody my business card and they called me with their legal issue, or a nurse filled out a referral document and emailed it to me and I followed up with the client. Now I have a few other clients that I've gotten through word of mouth, other things like that. But my point is, signing an MOU with a small hospital is probably not going to be enough to get you referrals. It's really about finding the medical providers that want to explore something new and getting their interest. And it's going to take time. Like, that's the nature of the beast. So I know that folks are worried. I'm worried about being able to demonstrate that I have done the work and I've had outcomes, but it's just a process that I've had to accept cannot be rushed, right? The last point is that you might want to prepare to be a generalist. I walked into this thinking that I would be a referral service and I would either hand over certain cases to other practice areas in my office, or I would try to take primarily public benefits cases. But in this rural setting, what's been more useful to my community is to go to meetings, go to meet doctors, go to meet patients, and listen to what their needs are, and learn how to identify the ones that I can't refer to my colleagues. This is maybe not the typical legal services model, historically speaking, because we tend to, this is something my boss and I talk about, we tend to like sit in our offices and wait for somebody to call us with a specific legal issue that we have a practice area that can take care of. And to go out and try and figure out what we're not doing and learn how to do it it's been very intimidating for somebody fresh out of law school. However, it's given me flexibility that my colleagues don't have. I wish I could cite the paper. I wish I'd pulled the citation, but I remember reading in a law review article recently about how about MLPs can be preventative care in the way that doctors provide preventative care. That's also not the way that legal services typically are administered. Typically it's an emergency, it's reactionary, but I can identify things that are happening and I can navigate folks through them and hopefully avoid a crisis. But that requires me to be kind of a generalist. My last question before the discussion questions at the end, because I have just been so vulnerable and shared my oops moments with you, is if you might feel like sharing any roadblocks, pitfalls, barriers you've encountered in starting up your MLPs.
Nola, there have been a lot of oopsies in the field. Because the National Center has been here to help people navigate through and overcome those oopsies for it's definitely longer than my time. For as long as the National Center exists, that's one of the purposes it serves. So I'm hoping folks are willing and able to share with Nola, who is starting this newer maternal MLP in a rural area upstate New York, which also has established MLP work going on. Some of what you've managed to overcome. I always like to say, and I recently said it at a conference, that I think the oopsies teach us more, much more than the successes, because often you miss the success. You don't even, you're unless you're truly tracking carefully what you presume to be a success up front. Often it's the oopsies, the mistakes, the glitches along the way that teach us more. So anyone willing to share what you've discovered along the way, even if you are still trying to overcome that challenge?
Oh, hi, I'm Jennifer, and I'm in Buffalo, New York, as part of the Medical Legal Partnership of Western New York. We've had a pretty established MLP at some of the adult hospitals, but established this MLP in the Children's Hospital probably about a year ago. So we're still developing that. I think one of my biggest challenges that I'm continuing to overcome is getting clear and concise retainer and authorizations for clients when we start working with them, because as everyone on this call probably knows, issues snowball and can be kind of bigger than what we can accomplish with people. And then I find myself sometimes, usually too late, thinking, how do I close this relationship? Now I'm answering questions long after I should be, and I'm becoming more of a helpline than I am a legal service, which I don't mind, obviously, because we're trying to still grow our program here. So I want to be of assistance as much as I can and get the word out. But that's one of the challenges that I've been having, is figuring out when it's appropriate to have a client sign a retainer and what that retainer says, and then going back to it when, the issue changes and stuff.
I'm really curious. Anyone have any tips to share, or even examples, even if you want to follow up with Jennifer afterwards? But that we've certainly, I'm sure it's a shared challenge, Jennifer. Let's see if someone has some tips for you.
This is Courtney from Mental Health Advocacy Services in Los Angeles. I just want to jump in and say, Jennifer, that's also a huge issue I experience, especially with client mothers who have mental health disabilities. It can be hard to close that working relationship. So closing letters has been helpful, even if it's not a full case and just an intake. I try to send those out through text, through email, however works for the client, so that they know, if you do have other questions, call our general intake line, don't call me directly. But it is a struggle. And I also, another oopsie that I'm still experiencing are when I'm creating these partnerships, I'll advertise our legal service areas. And then for immigration or family law that we don't cover, I'll say, I can always provide advice and counsel and referrals. But then it does kind of cause issues when clients call for family law or immigration, expecting me to take on their case. So I think communication can help so that providers and clients know how exactly I can help. And then that, making sure our partnership relationships are strong by preventing those miscommunications.
I will mention that one thing, and this may be incredibly obvious, but since I have started utilizing it appropriately, it's been so helpful. Our organization uses like a digital signature software. I think it was called HelloSign. Now it's owned by Dropbox. But for folks, especially like young moms, I find that folks generally have their phone. And if I can email them a release or retainer agreement if I need it, or whatever documents I need signed, literally they just have to tap a couple of boxes and then it's signed and sent to me and I can put it in their file. And I never have to like mail them paper. I never have to get something. They never have to go to a post office. That's been the best way for me to get all the documentation I need to like keep a proper file and close it for compliance purposes. So.
I'm wondering, is anybody from the healthcare side, because healthcare deals with this, right? And your patients are sitting there wanting to ask one more thing. And, it's uncomfortable in the exam room setting to have to sometimes say, we have to set another appointment. So healthcare has been dealing with this. I also know from the legal aid setting, and it is a frustration for legal aid because your clients have all of the problems. And sometimes you aren't able to serve them with the same or even a different problem in the same year, depending on the funding and resources. It's a very complex setting. Anyone, perhaps from the healthcare space, have any tips about how this is managed, how those expectations are managed, perhaps up front, how you triage, or, what are some of the tips that you may have for the legal services providers in working with patients who similarly have complex or multiple medical issues that once you get them in the door, that's the time to talk, but maybe you have to set up another visit.
Hey, Bethany, Roxy here. Hi, everyone. Hi, Nola. I am with Georgetown's Health Justice Alliance, the P-Law Project. I did want to share, although I am an attorney, but I've had experience in this in the past from the healthcare setting, and what we have kind of worked at on their end is to make sure that we are rerouting folks back to their healthcare providers. So Jennifer, I know you mentioned how do we like to close that loop, and Courtney and Nola both shared about like the closing letters or having the documents, either DocuSign or something to like close that. And so we do that as well, but also to encourage folks to keep in touch with their providers, because there's some issues, like we don't do mental health care, but obviously there's social workers at the hospital who are able to intervene. And so in order to also make sure they do comply with attendance for appointments and that they're getting these cares, because these are health harming legal needs, that they do go back to the nurse, the provider, to make these appointments. And then also if they're needing additional legal services, that they are then reconnected to us. But we have health screening. This is like a shameless plug for our session next week. But yes, we will be sharing more about that, but that we do have screening questions that we've integrated into the provider's questionnaire that they ask at every appointment, in order to make sure that folks, even if they've come back later, that they are being connected back to us, and that they are still making their appointments as well, just again, because we want to kind of close the loop between their health care and also their legal needs.
This is Holly at Dartmouth Health. I'm going to address the question that was just put in the chat. And we actually just had a new lawyer. So the question is, any former clients to provide feedback on the forms being used. We have a new lawyer that just joined our MLP, and he's coming with a fresh set of eyes, which is amazing. And we just had one of our referral forms sort of ask the questions differently in the same form. And so that was client generated. It was really easy to make that switch. Our lawyer sort of initiated it with me as the project manager, and we made that adaptation. I think having patient or participant eyes on things is really critical, making sure it's clear and and helpful overall. I would say the other pieces from the healthcare side of things, especially working with rural populations in New Hampshire, is the communication piece ahead of time as much as you can. We also have our lawyer sitting in our clinical rounds every week with our teams, and on our referral form, a client is able to put, I want communication back to my clinical team, yes or no. And so that allows that whole group to sort of talk, so that if someone is seeing one of the patients that our MLP needs to see, our lawyer in particular, that they are making sure that they're connecting during that patient visit. And space is always an issue in clinical settings. So we have several common spaces, or we'll know where the vacant office spaces are so that a patient can then transfer over with either a community health worker or a MLP lawyer, and make sure that everything is done in that visit, because there are a lot of barriers. Even though DocuSign and things are really helpful via mobile phones and things, we do have a lot of unhoused populations, patients that move around a lot. And so we want to make sure that them coming back, that transportation isn't a barrier, those kind of things. So trying to get everything done at once. We also are finding regionally that we have office space with our New Hampshire legal assistance partner down in an area where many of our patients are traveling from. So it's really nice that we can also sort of have this satellite office option where patients can be meeting in the law office down there, or the medical center, depending on where sort of they are that day.
That's amazing. Yeah, no, I mean, space has been a big hang up for me, because part of my MOU, right, is to give me a space at the hospital to hang out and meet people and do some screening. But so far that has not been able to find a space for me to physically show up. And in the end, at the end of the day, after developing all of these relationships with other providers, I'm not even sure it's the right place for me to be anymore, right? Because how long is somebody at the hospital when they have a baby? 3 days, right? Not the place to maybe catch them. So space is, that's such a good point you make about like, where are the people? How do we meet them? That's one reason I think I've gotten so much out of these relationships with community health workers who are doing home visits for newborns, because they are in the spaces, and working with them to develop those relationships. And I did want to mention on the screening note, I think that having that interprofessional perspective is really useful. So when I met the folks from Cornell Public Health, and they showed me their screening tool for pregnant folks. I mean, at first I was so happy that it already existed, but I was able to tell them, hey, you don't ask any questions about lactation or work or paid family leave. Have you thought about asking them about their plans, if they need help getting the right documents? Do they need a letter for their employer? So like having new perspectives and having multiple perspectives from folks. And somebody mentioned having like client eyes on it to tell you what they're picking up on. That's really helpful too.
Nola, before you transition, will we be able to address what Julie mentioned? I feel like it gets to what there's like a common thread here about client or patient education.
Yeah.
Translating a lot of information, but making sure we put the clients at the center.
I mean, I'll plug what Roxy is probably going to talk about next week, but I reference some of the other screening tools that PLAW uses, and some of the stuff that is provided. I'm looking at the wall because it's pinned up on my wall, but some of the information sheets that NCMLP points out, which is like about filling that gap between like what's a need, what's a social need, what's a legal need. And there are some really good existing screening tools that I think put those needs in words that don't make them sound legal, right? Like, are you having trouble getting to your appointments? Or are you having trouble paying for your medications? Those are questions that are not inherently legal, but if the answer is yes, I cannot get to my appointments, or no, I can't afford my medication, then we know as legal services providers or social service providers that there might be an intervention available to this person, and we can identify the need. But it has to be framed in the right way. You're totally right, Julie. And I think part of that, the best thing I can recommend is looking at some of the existing vetted screening tools that are out there.
Yeah, and I think Julie, I wouldn't, for healthcare providers sitting with patients that are partnering with, or even just doing referrals to, and maybe they don't have a partnership yet, we wouldn't start with or ever recommend a question that says, do you have a legal problem? Or, something in that vein, because even lawyers need lawyers to figure out if they have a claim on a problem that they think might be legal in nature. And yes, to what Nola is recommending, just want to reiterate, those social needs, or just asking someone, do you have a utility problem? Are you having a problem paying bills? Are you caught up on rent? Or, the employment related questions, such as what Nola mentioned, is your employer offering you space? Maybe that's not even because that's a really, finite setting that you're identifying already. You're already setting it up in a way that may not capture the broader legal issue at stake there that needs to be addressed. And so it's would never recommend, and we wouldn't at the National Center. And I don't think any MLPer on here would ever say start with any questions that say, do you have a legal issue? It's really finding out what is really going on in that patient's life, quite frankly. Okay, going back to you, we have others.
Yeah, no, I was just going to say really quick, Holly's comment. Holly said something that I have been super interested in doing at some point, having an MLP lawyer attend established patient groups monthly. Last week, there was 100% referrals made from clients in a pregnancy group where our lawyer was doing a mini session. So cool. Something that I've talked about doing. I work closely with I work closely with a medical student at University of Buffalo, and we're trying to pull together some data and do literature reviews. And we've talked a lot about how can we do an informational session for folks who are pregnant that also includes things outside of that includes not only the typical pregnancy related healthcare stuff, but also some of the social stuff, and maybe brings up some issues that people didn't anticipate. Super cool. So Holly, I would love to hear more about that, and I might email you about it later, because I'm pretty sure I have a whole list of all of your emails, and now you're cursed. Okay, let's see. We've just finished visiting each of the 14 clinic locations, the types of legal issue needs we seem to see, reminding them what is not a legal need. Yep. Oh yeah, that comes up a lot. Finding housing for an unhoused person is not a legal need, but it's something that comes up a lot. And it's so hard when people call and they're like, I need housing. And you're like, I cannot provide you with housing. Here are some places you can go. I can try to preserve your existing housing, right? So tough. Okay. So this is my last substantive slide, summing up what I've gotten so far out of this. And I do think I've benefited from having more than a year at this organization, right? So this is not just me reflecting on 5 months of experience. This is really me thinking about, because I have been thinking about over the course of my externships in my 3L year, my time working at Law New York, because let me tell you, I was so tired of doctrinal law stuff. I spent way too much time here. And yeah, anyway, I've been a hole in their wall for a long time, but there's a lot we don't know. There's a lot that I don't know. Did the slide not transition?
I don't think so, Nola. Sorry to interrupt you. I'm not sure what may have occurred, or if you need to reshare it.
Yeah, I just need to reshare it. It says it stopped. I think I maybe got an update notice that
Zoom. Let me know if you'd like me to hop in and help.
No?
There we go. Yep, perfect. Thank you.
Thank you for interrupting me. There's a lot we don't know. We've been talking about this when we've been planning for these collaboratives, but there's just not a lot of literature out there about perinatal medical legal partnerships yet. So we're trying to work to fill those gaps and figure out what we can from what we do know. And we do know that there are documented successes in the pediatric context, right? And we also know, I know from my personal experience with the folks I work with, that in Rochester, one attorney has been able to accomplish quite a bit over the last 10 years for a whole slew of patients. And we know that that has been valuable to the hospital because the hospital is paying for it in part, right? But the last thing I will say, in the 5 months that this has been my sole job, because up until now, I had externed in domestic violence, I had externed in public benefits, in eviction prevention, But now that this is my whole job, just getting this MLP up and running and going out into the community, this has been an excellent way for our legal aid organization to develop a connection with the other organizations in the area. I think it's become kind of obvious as I've started having meetings with folks that lots of people don't know what we do. A lot of people thought that all we did was eviction cases, but I've been able to say, no, we actually can take public benefits denials. We can actually refer for health insurance denials. We can deal with consumer debt, right? Like reentry issues, and just being in those spaces, in community spaces, has enabled us to broaden our reach and get more people funneled in our direction and help people identify, like the big question we've been talking about, right? What's a legal need? Does my problem have a potential legal solution? It's not obvious, but the more that we can get out and talk to people about the work that we're doing, the more it becomes clearer that that we could be doing more to reach folks. And personally, as somebody who grew up in this community, getting to know all of these resources and getting to find out how much people care and how much we really can do if we work together has been invaluable. So that's the end of my substantive, the substantive portion of this presentation, although it's been didactic. But we've got some time, which is good. That's what I wanted, to talk about some of the issues that have come up as we've been talking. I don't know, we don't have to take them in order, I guess. We could. What do you think, Bethany?
I'm deferring to you, Nola, and the group. It is totally up to the group. This is it's a collaborative learning experience. And so in any order that you all want, you can start to have a discussion about what we teed up at the beginning. For those who are in or closer to the healthcare provider setting, again, the question was for discussion: what is your current practice for patients or clients who are affected by substance use disorders? Does your institution conduct or require those universal urine drug screens? Are you doing verbal screenings? What do you do after someone screens positive? For those that are in the legal setting, legal services providers are adjacent to, are you taking on family court cases, neglect cases, and how do you navigate your relationship with the healthcare staff on those sorts of cases or issues? Some of what I would love for this group to dive into a little bit more is that question that we ask right up front. How are you as MLPs or individually as organizations and entities addressing racial inequities in maternal health through your MLP? This is something the National Center is going to highlight more and more in an explicit manner. And so I'd love to begin having this in-depth conversation with the group focused on maternal health to address the racial inequities in this space. And then, of course, the fourth and final question was for those of you who are working in the pediatric context. How can you practice better what you're doing? And we started to talk about this, your identification of, your screenings for, and your supporting of the needs of pregnant or postpartum, let's remember postpartum individuals. So in any order, just wanted to remind folks what those discussion questions were. And Nola, you're welcome if you want to, from those who have already shared or not shared. Feel free to call anyone out to facilitate the discussion. Let me know what help you need from me.
Yeah, let me just give a little bit more context to 2 and 3, because I think number 1 is pretty straightforward. Although I will mention for number 1, I think our OBGYN office also does a urine drug screen when people show up for their initial prenatal visit. So it's really pervasive. But for number 2, one of the reasons I ask is because I said that I refer these folks to assigned counsel, but there's only 3 attorneys in the county that take neglect cases. So when I say I refer them to folks who are overwhelmed and already taking criminal cases, custody cases, and they are in no way able to show up at the hospital and advocate for these folks when CPS comes. So for me, it's kind of it's a wish, right, that I could be a bigger part of this conversation. And then with number 3, I put it on there, even though it has not come up much, if at all, in my presentation, other than when I identified the need, because I am not sure what next step to take, and I'm not sure I am the person to make that step, right? I'm curious if other folks have taken those steps to address racial inequity in the provision of care. So, other than that, I'm sure somebody must be dying to tell me something if they want to unmute. Any healthcare providers want to tell me about their practices when it comes to folks affected by substance use?
I think one of our healthcare folks actually had to log off a little early and had messaged me, unfortunately. And if anybody's actually from the legal services side able to share their perspectives, that would be super helpful. Maybe I can help encourage some conversation as well by saying, with any of these points on the screen for discussion, is anyone seeing opportunities for policy work to be done, the greater impact work? Nola, mentioned that and Nola, I could be mistaken, but is it a New York state level requirement to conduct and require universal drug screenings?
No.
So this is a hospital-based policy?
Yes.
Okay. All right. So when I pose this question to the group, are you seeing any big P, little p policy level opportunities that and it doesn't have to be Law New York, through Nola's work at the MLP with the current partners, but if you are like Nola in your state and you're seeing this as a systemic issue, even though it may have been well meant to be able to better connect individuals to care or address possible, as the Child Protective Services intends to do, protect children and families from dangerous or neglect situations. What are some of the policy opportunities that you may have identified or, suggest can be taken on? For session 4, I'm bringing the Jeopardy music.
This is Clinton Householder. I'm muting again from Community Legal Aid in Northeast Ohio. So I don't really have any comments regarding the policy issues. I'd have to give more thought about that and what we've done in the past and ideas for the future. But I will comment on questions 1 and 2 for discussion. So I know in the past, our program has attempted to partner with addiction treatment providers locally to create MLP projects and programs. We had some restrictions because we're funded by the Legal Services Corporation in doing that work. From my understanding, I think it had something to do with the fact that some folks were still perhaps on probation or serving parts of their sentencing. In other cases, they were in institutional or residential treatment by way of court orders. So that put a lot of restrictions on our side of things with being able to help the individuals in order to comply with LSC restrictions. And then what we found in those partnerships as well is that a lot of folks were facing barriers relating to the social determinants of health, in part because of pending offenses. And their goal in getting referred to us was often help sealing the criminal records that were a barrier to their housing, a barrier to their applications for public benefits. And in many cases, the folks just weren't eligible, unfortunately. So I think the restrictions from LSC combined with just the circumstances that we were seeing with each referral kind of caused those partnerships to die out and not see success like we've had with some of our other MLPs. And then for question 2, our program doesn't take abuse, neglect, or dependency cases per se, and that's because oftentimes those folks in Ohio are able to get court-appointed counsel when they're charged with those offenses. We do take family law cases generally, where if someone's referred to us through the medical legal partnership, we can help them with civil protection order, divorce, child custody dispute, child support issues, kind of the full gamut of family law services. But once there's an abuse, neglect, or dependency charge filed against that person, oftentimes we have to step out due to the same LSC restrictions that caused problems for the folks who were involved with substance abuse treatment. So it's an unfortunate problem that we've had in the past. And from my understanding, our MLPs that we used to have with the addiction treatment providers are gone or not going well, from my understanding. I don't work with that team necessarily, but hopefully that helps with perspective.
Thank you so much for sharing that, Clinton, because we know that LSC really supports medical legal partnership and has highlighted often over the years since prior to, quite frankly, 2016, when I started coming into the MLP space more deeply. But LSC has really supported MLP and as an approach to address, and during those years, the opioid crisis. And so it's really important for, I think, LSC and policymakers to understand what, and I still see this as a policy barrier and opportunity, to understand what these restrictions place on their ability to carry out their work. And we do know, even in the state of Indiana, they're doing some awesome work. Perhaps not utilizing LSC funding, but building a medical legal partnership with a recovery services provider. That's their setting. And so I just want to thank you for sharing that, because of how much is being done for perinatal patients to improve maternal and child health outcomes by addressing the substance use disorders that these patient populations, as well as when we are talking about babies, right, for the neonatal patient population, right, what they're facing. It's really important, I think, for agency folks to better understand those very real barriers. So I will certainly be following up with this entire working group to get a little bit more information and detail about what Clinton has shared and other barriers that you're facing in actually carrying out your work. I think it's really important for us to carry that message, those stories, that information up to folks working even at DOJ, Office of Access to Justice, and the Legal Aid Interagency Roundtable. Thank you for sharing that.
Sure thing.
Sorry.
Oh, sorry, Nola. I was going to say, on a related topic, Nola, I know you mentioned special education earlier and how you're delving into that area of law as well. That's another practice area, I think, where some of those same restrictions come into play for these families. For example, here in Ohio, when a parent is charged with truancy relating to their child, right? That's really a criminal offense. And most of the courts in our service area don't appoint counsel for that. They might for the student, but they don't do it for the parent. And due to some of the restrictions that we have as a LSC funded program, we might be able to help the parent with school meetings and IEP team advocacy, due process, other disputes with the school, but we can't go to juvenile court and represent in the truancy case. And those issues often go hand in hand, right, with the advocacy. So that's just another thing I wanted to add, because it's related and I think a barrier to the success of some of these programs. Sorry to cut you off, Nola.
No, all I was going to mention is I did that thing where I gave a definitive answer to a question, like, does New York State require prenatal, postpartum, urine drug screens? And I said no, and now I'm a lawyer and I'm like, well, let me walk that back. But my point is, my understanding of the current law related to substance use disorder is the current law rather related to, I think the way that it's usually referred to is neonatal abstinence disorder, or the term of art in the federal statute that requires some level of reporting is newborns affected by substance use. I'm not saying it correctly, but there's a really complicated web of federal policy under CAPTA-CARA, which is part of what funds CPS. And what delivers some mandates to CPS in terms of what they do and don't have to do. There's some reporting requirements that hospitals do have to follow, and I'm not sure that it's entirely clear. At least it's not clear to the folks that I work with what they're expected to do. And I know that my Department of Health is issuing like new guidelines all the time about what they do and don't have to report, and what they and a lot of it defers to hospital policy. I'm happy to send out, by way of example, what this like last FAQ from the Department of Health looks like directed at hospitals in terms of what are they required to report to captive care to the federal government. But a lot of it, and I'm sure this is the case for a lot of their programming, says defer to your hospital's policy or defer to your hospital's risk advisors. There's a lot of deference to hospital policy here, and I don't know that there's a uniform understanding of what is federally required when it comes to infants affected by substance use and what hospitals are doing of their own volition. So I'm not the expert in the field, but I did want to offer that clarifying point that it's not so straightforward as I made it sound.
Really good conversation so far. I want to see if anyone else has some more. And there was at least at the Yale hosted, actually jointly hosted by 3 academic MLPs, but up at Yale, MLP convening recently, at least one researcher and MLP practitioner who should soon be publishing a paper that addresses at least the hesitance because of the various restrictions we've talked about and barriers we've talked about so far of MLPs to engage in those child welfare issues, and really getting us to move past those barriers to work with entire families. So I think that paper should suggest some ways, maybe not all the answers, but some of the ways we can move beyond that. And I'll happily share the individual's information if the paper isn't done yet, but it will be in the journal that features the MLP conveners that met recently at Yale. Anyone else want to chime in here? Anyone finding ways to explicitly address racial inequities in maternal health?
You read my mind. I just put that in the chat, but I'll read it. In my county, I mentioned that there's been some comprehensive interviews done by folks at Cornell, and they tell us that the racial inequity in prenatal care has been in part driven by distrust in medical care providers, not feeling heard, not feeling seen, feeling unsafe. And I wonder, when I think about what my role might be, if part of that is revitalizing those relationships and restoring trust. But like you said, I'm just interested in whatever comments folks have, because this is still something I'm working on.
Hi again. So over here, hi, in DC, our partners with MedStar, and recognizing their role, obviously, as one of the leading healthcare providers in DC in the DMV area, we would actually have a implicit bias racial inequity training that happened almost, and I'm sure Laurel can speak on this tomorrow as well. It was every few months, and it was with the entire department to address some of these issues and to bring in real life stories from patients so that they knew that this isn't just like a general, right? Like this is actually happening right there at the hospital, and understanding that this could have been your patient who shared this about, their service or their care that they received. And so it was very interesting and eye-opening and well received by the providers, and also for me just to sit in on that, because then when those same patients eventually became clients and I would hear, like, oh, I don't trust them, or they didn't listen to what I was saying, it also allowed me to provide feedback back to the providers that says like, hey, there's still work to be done. So it was very, very informative, and it was, I think, very helpful in order to recognize and then also address these issues.
That's amazing. Do you know who orchestrated those meetings with patients? Was it the hospital? Was it somebody else?
Yes, so it was the hospital, but then they brought in folks who specifically dealt in this field in order to do that.
Terrific.
Yeah, so brought in some experts, some leading experts on it in order to be able to facilitate those conversations. So again, it didn't feel like it was your boss or it was your supervisor that was asking you to answer these questions. It was coming from an outside, a third party, to lead the discussions.
Roxy, thanks for chiming in there. I want to acknowledge that for MLP practitioners joining in on this particular learning collaborative on maternal health, those of you working on child health, remember MLP itself is a vehicle or a tool that can be used to address various inequities, including racial inequities. And some of what the field is trying to do is do this more explicitly and expressly in their work, coming up with the specific aims. And some of this requires some data. And as we know, there are entire movements to disaggregate data so you can find out what are the inequities. And this has been especially important when working on maternal health. So if I can share a tip on behalf of the National Center for those of you working on maternal health, one thing that you may want to consider doing is really just, looking at data sets a little bit more, right? To figure out, are we getting accurate information to paint a picture that is actually informing us of the inequities in the community as it relates to racial inequity in terms of maternal health. The other thing to make note of is when it comes to racial inequity in maternal health, this cuts across, as the data sets have shown, this actually cuts across income groups. So because many of you are from settings, both healthcare and legal services wise, that focus on income eligibility, right, for services, the second and final tip I would share is on those working groups, right, really reach out to others who are practicing with patients who may fall outside of the income group and are willing to share their stories. The Black Women's Health Imperative, also based in Washington, D.C., is a great national organization and resource for the research. They also do the advocacy work, policy, legal, and otherwise. And it's if you're looking for a resource, as well as what John Richardson who presented on our session one presented on, those are two great resources for diving into the data that you may need to be able to come up with the principles, the goals to work towards the improved health outcomes as it pertains to the racial inequities. And let me just also thank you all for doing this work. You're already doing it. You just got to say it. That's all. Well, that's not all, but it's part of it. Part of it here. It's really important to say it. All right, so we're a couple minutes over time. Nola, may I close us out? Thank you. First, can we just scroll to the survey link slide, Nola? And then let me let folks know that, number one, let me thank Nola Booth from Law in New York for presenting today on session 3, March 15th, 2023 of our Maternal Health and MLP Learning Collaborative. We would greatly appreciate receiving your feedback, especially in advance of session 4 happening next week. That way, all of our MLP practitioners who are serving as facilitators, especially the Georgetown HJA team, you just heard from Roxy Richardson as well, are able to capture some of that feedback and information and continue to integrate it into that final session, as well as any follow-up information that the National Center can provide and send out to you.